Hey everybody, and welcome back to the Vent Lecture ATV edition. We're going to be on part 5 or 6 right now. I've kind of lost track. We have cut this up into a lot of parts, but for good reason. We're answering a lot of questions. What are our new ventilators capable of? The new Parapack ATVs that we got at the job I worked for a long time ago. Why and when can we use these non-invasively? And how can we use these non-invasively? And I know that we have how do we troubleshoot down there. That's more of the lab portion. And I'll see if I can get one of those Go cams to try and do a live action lab that we put on so you guys can know how to, sort of troubleshoot when the vent starts hitting the fan. Okay, moving on. We've actually went over all of these, and we're not going to really answer a question, but we're going to go over something, and it's called the rule of P's. And it's prior planning prevents piss poor performance. This is actually a military saying that is super hard to say if you're dyslexic, and I am dyslexic, so I had to say it really slowly. But what we're going over is respiratory resuscitation. And these are kind of the steps I want you to follow when you're going through respiratory resuscitation. This is one aspect. We're going over the respiratory section of how you come about these resusces. So you ask yourself, what is the patient's status? Is he a crash airway, failed airway, difficult airway? And those 3 algorithms are actually from the Ron Wall's book, Manual for Emergency Airway Management. An amazing text, and I'm going to try and have those algorithms up on my on the website, so where you can maybe a PDF document to where you can actually look at them and sort of follow them. They're amazing. The next question: are you initiating a vent or are you taking over? So real quick, crash airway. Unconscious or near death, failed airway. You've already tried intubating, their sats are dropping, you're not able to get a tube in. Or they blew their face off with a shotgun. Difficult airway, 500-pound plus and 5 foot. Or maybe a cancer patient who has masses all over their face, mouth, and neck, has extreme swelling, extreme edematous. So those are some things you can actually think about with those 3 algorithms. Those are the big overshots of them. So I want you to ask yourself, what is their current process? What is their pulmonary status? Remember, we went over this in maybe, I think it was video 2. Is it a type 1 or type 2 respiratory failure? Asthma, COPD, CHF, ARDS, pneumonia, a regular resus. Is that a type 1 or a type 2 respiratory failure? Asthma, type 2 or type 1? Type 2, perfect. CHF, type 1, exactly. Pneumonia, type 1, perfect. You guys are rocking this. No doubt in my mind that you guys will be able to go onto a scene, look at this respiratory patient, say, I have a respiratory resus on my hand. This patient is a type 1 respiratory failure, CHF, and be able to move on from there. So, what equipment and why? So you've already identified what the patient is. Type 1, type 2 respiratory failure. What is your goal? Well, let's say for this imaginary patient, I have a CHF patient. I have a CHFer who's a type 1 respiratory failure, has fluid back up into their lungs. What tools do I want to use to accomplish it? Well, I'm going to need some CPAP. I'm going to need to push that fluid out. Those are the tools. Those are the questions I want you to ask yourself and be able to answer on the fly in the middle of a high-stress situation. So here's some patients that we sort of do the same exact thing over for. 35-year-old male, unconscious, respiratory rate of 4. Pulses are 90 and weak. He's got meiosis, blue lips, the syringe still in his vein. What's his patient's airway algorithm? Type 2, exactly. It's a ventilation problem. He's unable to move air. He's obviously a narc overdose. How are we going to protect his airway? Well, you can BVM him, which means what? You could VVM him. Now, albeit for most narcotic overdoses, they tend to be fixed relatively quickly, and there's a high risk for aspiration. So on a patient like this, if I had a lot of hands, I would have 2 people up at airway, one holding the seal, another bagging lightly, and I'd give him some Narcan just to bring him up just ever so slightly, so where he's protecting his own airway, but he's still relatively unconscious, and I can work from there. But don't forget that ETCO2 on him just to make sure you get all your backs behind you. So what's his airway algorithm? Number 2. How can we use a vent to protect his airway? Well, a VVM if you need it, if you don't have the hands. Moving on. 12-year-old, tripoding, lethargic, respirations 24 and shallow. She's auto-peeping, and it's an initial wheezing that is now absent. And everybody's buttholes just go because it's a kid, and she's obviously having an asthmatic attack, and she now has a silent chest, so everybody's losing their shit. But I don't want you to worry, because you already know what the patient's airway algorithm is. It's a ventilation issue. It's type 2. She's having an asthma attack. You know what medications to give, and you know how to fix it. So we answered the first two questions. What's a patient's airway algorithm? Well, it's not a crash. It's not failed. It's not difficult. So she's not really in that sort of section, but we do know her respiratory failure. It's a type 2. How can you use the vent to protect her airway? Well, you could do one of two things. Actually, even three things. You can hook up CPAP along with your neb, along with all your other treatments and medications that you're going to give, albuterol, Atrovent, some Solumedrol. If it gets crazy out of hand, Epi. If it gets even worse, magnesium sulfate. You have all these medications in the palm of your hand that you can give to this patient, but you can also give them a combination of things. CPAP with all those medications. You can BVM them with all those medications, which I had to do multiple times because I didn't have a CPAP to give them in the past. I had to use a BVM. Or you can use the fake BiPAP, which is just the BVM strapped to their face, or the VVM strapped to their face. Now remember, the VVM strapped to their face is a lot like using a CAD as a splinting device. It's really not meant for that, but it'll work in a pinch. And if it's cleared by your medical director, then you know what? You can use it. So be sure and talk to your medical director about that VVM strapped to their face. But what can you do? CPAP, and you could also bag them. Those are both not arranging any protocols, and those are very easy to use. Don't forget to set up your neb in line with your CPAP or your BVM. Moving on. Patient number 3. So this is a cool one. 56-year-old, morbidly obese male, in-field cardiac recess. You guys rocked out. You recessed him back. Not with these hands. You yell out squat 81. That's how we do this. But you look at the EKG, and he's got a narrow complex second-degree type 2 Wenckebach. And this is for the medics. I know it's a little out there. With PVCs and marked reciprocal with inferior ischemia. Inferior ischemia. Ooh, that's a big one, right, guys? We're thinking, we got this 12 lead. He's a recess. We already got him on the way to the hospital, and his blood pressure is 80/50. Now that's a lot I just threw at you. That's an extreme amount that I just threw at you. But I want you guys to sift through it. What is this patient's airway algorithm? Well, he's unconscious and near death. He's a crash airway. How could you use the vent to protect his airway? Well, the same way you would normally use a vent. You tubed him. You either have an extraglottic airway in him, or you have a tube in him, and you just set up the vent like you normally would. Why did we mention his rhythm? Well, inferior ischemias that tend to affect the right ventricle tend to come with a lot of weird rhythms. So a narrow complex second-degree type 2 is really weird, and throwing PVCs every now and then, like a run of PVCs, maybe even going to VTAC, is kind of normal for those inferior ischemias. So I want you to think about why we threw that out there, because I want you to look at that BP. We're not going to put this patient on too high of a pressure, on too high of PEEP, because we don't want to create too much pressure within inside that chest to dump out their blood pressure. What is that? That's what that means for your vent settings. You want to be able and be cognizant of the pressure within inside their chest. Whenever you're hooking them up to a vent, you don't want to have that incoming pressure too great to drop their blood pressure again and send them into the exact same thing they were before you pick them up, dead. Okay, so we're going to go on to this stuff on the next video. Thanks for going through all those patients with me. Now what we're going to do is finish out the P's on the next video. Stand by, guys.